Thank you very much, everyone. So my name's Dave Triska. I'm a GP partner in Surrey. I was the digital first lead for a couple of years for Surrey Heartlands, one of the most mature ICSs, and tasked to give a talk as a practicing GP about going virtual. Feels a little bit like being thrown into a political bear pit at the moment, but I hope I can provide some colour to what Jacob's going to talk about, which is the how do you deliver this side of things. I thought, first of all, really I wanted to look back on was the scene at the start of the pandemic, perhaps not in the way that you think, which is about where we were in general practice. So I think we're very good at looking at the now and critiquing, but we perhaps don't always think about where we were. And at the time, we'd just gone through the winter of 2019 with headlines in the Daily Mail saying there was an 8-week wait to see a GP. So I think it would be fair to say that all was not rosy. Approaching into that pandemic working, I think a very good analogy would be to look at what would we do in business, and bear with me. So looking at how we practiced during that time, essentially we had what you would refer to as 30 to 40 unscheduled client meetings during the day, which was scheduled for 10 minutes, regardless of the need of the client, with no idea of the agenda from either party. And I think if one was constructing primary care from the ground up, that may not be how one would like to do it. So, as with all testing situations, my previous job was as a regimental medical officer for the Army for 10 years, we found that testing situations provide novel solutions and often unintended benefits. So what did digital bring? And what do I mean by digital? Now, I would like to think of digital as returning us to core values of general practice, not the move away from it which it is portrayed. And I think it's very important to realise that digital and tech is a tool, and how one uses it gives the importance of what that tool is. You can use a great tool badly and a bad tool efficiently. Witness all our electronic patient records and the rather difficult machinations we have to do with them. So what did digital do for us, and what did we deliver? Well, the pandemic showed that we had all of a sudden even less capacity than we did before. We no longer had a safety net, so patients weren't able to access us both through pandemic working restrictions and also through the sheer quantity of consultations that were needed at that time. So digital working, essentially for me, was about how do we deliver at that moment continuity of care with knowledge of those patients, so longitudinal care, which is the cornerstone of primary care and indeed probably the NHS, and how do we do that in a way that's safe and efficient for everyone. And Jacob's company was a huge part of this. So accuRx, for those who aren't aware of it, is a company that helps us deliver essentially data communications between patients and clinicians. And in my job as a primary care physician, the most important thing that I have to know is what is wrong with the patient and what do they need from me. Now, that may seem as if that's a very obvious question to ask, but I can assure you that if someone who's waited for 3 weeks to see a GP has to perform on the spot and give a perfect medical interview, regardless of the skills of that physician, they are going to struggle. So as well as that knowledge, what we delivered with digitisation of healthcare was preparation and asynchronicity. So asynchronous communication is where essentially we give people time. So the time that we don't have as GPs to do data trawling and understanding their needs, because we simply don't have enough of us, was actually now delivered through digitalised healthcare. So this is a mechanism through online portals, which our patients can access directly, often 24 hours a day, which is hitherto unheard of access to primary care, and have the time and space to make those assessments of their needs in a fashion that suits them. The important bit about this delivery is that it mustn't disadvantage those who are digitally not enabled. And of course, by freeing up that time to spend with those patients, by having patients able to communicate with us in a way that suits them, means the digitally less enabled are actually protected. So for patients, digitalisation of healthcare during a pandemic removed barriers. Rather than putting up barriers, as is often portrayed in the media, we broke them down completely. So I don't know of many medical specialties where one can access a clinician of 30 years knowledge at the drop of a hat with very little in the way of barriers to that access. You can access it repeatedly, you can access it as your need arises, you can access it without delay. So from a state where patients had an 8-week wait, at my own practice in Whitley, we went down to under 50 minutes wait to have senior clinician input to a case. This is the power of asynchronous and digitalized technologies, where it's the starting point for a conversation and a consultation, not the end of it for a patient. Technology is an augmenter, and I really want to talk to you about what did that look like in practice for what admittedly is a humble primary care centre in a small village just outside of Guildford. The first thing that we got rid of was appointments. There are no appointment lengths. Appointment lengths, as I mentioned in the starting address, was that a 10-minute appointment for any such problem seems completely ludicrous. How could I care for people who had palliative care needs? How could I care for people who were suicidal? It's impossible, and patients suffered as a result. And this is when I go back to what was it like pre-digitalisation, and patients were suffering in that system and did not have the care that they required. Now what happens is, because we have that communication from patients beforehand, we can assess their needs and actually provide them with the care that they need with the person who's appropriate for them. The clinician with the most need, the clinician with, the most knowledge, the clinician with the most experience, the right person, the right place, the right time for that patient. Imagine then, having had that appointment, you leave with an instant summary of what's happened to you. We all know that for most patients, less than 30% of what occurs in a consultation is retained. Leaving the appointment with myself at the moment, and any of my partners in my practice, the patient has a full digitalised care summary presented to them on their phone forevermore, telling them where they need to go, what they need to do, and indeed using technology with automated reminders about when their care episodes are, when they may need to reattend for tests, what they may need to do next. All of a sudden, what looks like a harsh and remote technology, which can be a block to care, is in fact a warm, enveloping blanket for these patients. There is no longer any reason they don't feel that their clinician is fully engaged with their care. Spinning out of this, we have a huge need for patients that is outstripping our demand supply at the moment for things like chronic disease care. Using technology such as group video consultations, community-based interventions are now possible with patients who may not have been able to access them during the pandemic. Systemic long-term condition management goes on apace, allowing us to draw in data from patients who are able to access us in that way, so that we can prioritise care for those who need us the most. It clearly makes no sense for us to spend our time chasing people who are well and don't need much for their long-term condition management, when we can use novel techniques such as what's referred to as Florey questionnaires, essentially long-term health condition questionnaires that the patients can submit to their GP, who they've probably known for a good portion of their life, who can work out if they have a need. So the future, why don't we all do this? Well, clearly I'm a convert, and I would say that we should. And I would say that this is something that can be delivered across both health and social care, and indeed in other sectors. What's the difficulty? Well, we enter a brave new frontier, much like in the early days of Afghanistan, that we were learning how to deal with patients with hitherto unseen injuries. We're learning how to deal with mechanisms of communicating with patients that we've never used before. Not everyone is an expert yet, but there is time. And in an NHS that's under increasing pressure, we must utilise the resources that we have and use them in the best possible way. So in summary, I would like to say that in my experience of pandemic working, technology has augmented clinical care. It's not replaced it, and it has allowed us to deliver a more traditional practice where patients are cared for by their GP at times that suit them with care that they need. Thank you. And Mr. Jacob Haddad from accuRx.
Thanks so much, Dave. And there's nothing more motivating for our team than hearing experiences like that from the front line. So I'm going to quickly talk about how we innovated during this time. And if you look at 2 years ago, if you had a mole on your arm or maybe a rash that you were concerned about, and you contacted your GP practice on the phone, they'd book you in for an appointment, you'd come in, you'd have it seen to, then maybe you'd be referred. Today, pretty much every GP practice in the country, if you contact them with that same mole, they'll send you a text message, ask you to send in a photo, and then they'll decide what's best. Maybe they'll send that photo on to dermatology for some advice and guidance. If 2 years ago you needed a fit note, you contact your practice, maybe you'd have a phone consultation then, but you'd need to come into the practice to collect that piece of paper. Today, you get sent a text message with a link, You can download it and then do what you need with it. And 2 years ago, if you needed a flu jab, you'd get a text, maybe even a letter telling you to call up the practice, speak to someone in reception, book an appointment. Today, if you need a COVID booster in most practices, you'll be sent an SMS with a link. You can follow it and book that appointment. Now, in all of these examples, those needs were there long before COVID, and those needs are going to be there long after COVID. We haven't built anything, specific to the virus, specific to the pandemic, but what the pandemic did was accelerate the urgency of addressing those latent needs and finding a solution. And often as a company, we look at the speed of decision making in healthcare and get quite frustrated and try and understand it. And when we do, we see a lot of decisions being made to minimize risk, not to maximize opportunity. Where can things go wrong rather than how can we improve care for these patients? And what happened during COVID is not taking those opportunities became a risk, because that patient who couldn't come and get their sick note couldn't get their benefits payment, or because that patient with a mole they were concerned about couldn't get it seen by dermatology, or maybe they'd come into the practice but put themselves and others at risk of infection. Video consultations is something that got an awful lot of attention all the way from the Secretary of State for Health, through to media outlets. And interestingly, we learned they weren't actually as helpful as everyone hoped. And I think Dave's description is a very good one of they are a tool in a toolkit, and clinicians and patients are very good at understanding when to use them and when not. Generally, we think of video as quite overhyped, but actually that messaging, that asynchronous communication that Dave talked about, is quite underhyped. It's quite easy if you want to write an article to put a picture at the top of a doctor in a white coat with a stethoscope. There's loads of stock photos of them and try and explain it, but messaging is sort of harder to wrap your head around how that helps. But to give you some idea of scale, for every video consultation we do now, we send 100 messages to patients, not appointment reminders or batch messages, but your vitamin D is low, you need to go to the pharmacy and get some. I've got your repeat prescription request, but you need to do this blood test first. Real clinical interactions that would have previously been appointments. And for some idea of scale, today in the NHS in England, there'll be around a million GP appointments, and around half of those, there will be a messaging interaction as well. Where this gets really interesting is when you look at the health economics. So pretty much every economy in the world is struggling with spiraling healthcare costs. And there are a number of different reasons, but one of the biggest is that over the past few decades, healthcare has seen negative productivity growth, where other sectors have seen positive productivity growth, because it's an inherently human profession where we're reliant on one-to-one interactions. But actually what Dave described of moving towards asynchronous interactions allows us to start to see those productivity gains. And so as a company, we look at healthcare and we see it as a communication industry. When we were finding our feet, we went and spent 3 months in GP practice just shadowing and understanding what people were doing, and quite quickly saw it was making referrals, getting second opinions, coordinating care, getting information to a patient. It was all communication. That's where the value was added. But also when things went wrong, it was because of a breakdown in communication. So we've got this vision that everyone who's involved in a patient's care can communicate with each other. Obviously, it includes the patient and their family. And that's pretty uncontroversial, but incredibly hard to do. Now, the big challenge coming, where we are now, almost 2 years since the pandemic started, is a lot has changed. And at the same time, actually, lots of things haven't changed. So if you're getting referred as a patient, it's still quite a transactional interaction where you don't really know what's going on between two siloed organizations, with, where all the communication just sits in that one letter. You've got type 2 diabetes, and you need those 8 quite simple processes of care: your feet checked, your cholesterol, your eyes checked once a year. You've got a roughly 50% likelihood of actually having all of those happen. And so all these challenges, if you're an ED doctor and a patient comes in and their renal function's low, you're trying to work out if it's acute or chronic, you still need to get on the phone, try and get hold of that GP practice, maybe wait in a queue, maybe you get sent their record by fax. So there's still a huge way to go. So how do we use digital and technology to address some of the current challenges? And when I say current challenges, everyone knows about the 6 million patients on a waiting list. There's many more patients who aren't making it onto waiting lists because they can't be referred at the moment. the 90,000 staff vacancies in the system, the challenges getting access to general practices, GP practices that haven't yet moved to such efficient ways of working. There's a few quick learnings I will whiz through that we need to take from the pandemic and moving forward. So one sounds pretty obvious, but sadly it's not. It's just focusing on the users and their problems, spending time on the front line, seeing the challenges people have, seeing how they work currently, and really understanding the root causes so we can help. The second is bottom-up adoption. What we mean by that is building interventions, whether they're technology or otherwise, that staff can just get on and use. They don't need to be mandated top-down throughout an organization. And that's what we saw right from the start of the pandemic. Where things worked well, it was because of incredibly decentralized leadership and smart, resourceful people on the front line. In March 2020, we went from around half GP practices using us to around 96% in a few weeks, because practices could just get on and find the tools that they need. They didn't have to wait to be told what to use. Third, we need to stay really simple and let staff innovate, which again sounds pretty obvious, but so many software systems get bloated very, very quickly because people want to add complexity to make them handle every single edge case, but actually you then lose so much flexibility. We talk about, we need to be really generic as a product. In the same way, you pick up a phone and you can use it for anything. One of the nicest things to see early on in the pandemic was this flurry of hundreds of different use cases that our users were coming up with, from how they communicate with patients who speak other languages and translating things, through to managing remote monitoring patient oxygen saturations at home, communicating with hospital departments. One of my favorite examples, super, super simple, but was just putting posters up in the car park saying, wait in your car and we'll text you when you're ready to see you. Stuff we never would have thought of, but when you give staff generic ways of communicating, they can innovate. Fourth, turn the pressures in the system into an opportunity and into urgency, something that's come through all the talks, because those latent needs will always be there, but it's times like this when things like the waiting list challenge, actually what it boils down to when you talk to a trust is we don't have a way of communicating with those patients on the waiting list. They can either phone up, but we don't have enough staff to pick up the phone, or we can send them letters. And actually what that is accelerating is a need for easier communication. And then finally, the last learning that we've really had through the pandemic is releasing early and often. And by release, I'm talking about software here, but really this is about iterating. In the same way that if you're doing quality improvement in a clinical setting, you want to get through many iterations. The first thing you design probably won't work that well, but it's only once you learn and go through that cycle that you get to something really effective. So here are our software releases. You'll see, each color block is a new release. We'll do that at least once a week, and there's quickly a ramp up of adoption. This is pretty unheard of. Like most software products in healthcare go through quarterly release cycles where loads of stuff changes at once, which means if something goes wrong, it's quite hard to unpick where that is. But also there's a long wait in terms of getting those latest innovations. So these are just some of our learnings of race through there. There's so much opportunity, so much to fix. But the great thing over the past 2 years is I think we've seen a glimpse of what's possible, and most importantly, debunked this myth that the NHS can't adopt technology, because it's not true. Thank you very much.